Today, we're going to dive into a really fascinating hypothetical case. It's one that really gets to the heart of medical training, ethics, and, of course, patient safety. So let's jump right in.
Okay, picture this. You're a senior medical resident. You're good at your job, you're skilled, but you're still technically in training. And then, bam, you're staring down a life or death decision, and the one person you're supposed to rely on, your supervisor, isn't there. What do you do? That's the exact pickle we're unpacking today.
All right, let's lay out the scene for this hypothetical situation. A patient comes into the hospital. Now, she's not a scheduled appointments or anything. She's a walk-in, which means the team has zero prior history to go on. They are starting completely from scratch.
And her symptoms, they are serious and they are happening right now. She's got this sharp, acute pain deep in her lower abdomen, and there's also vaginal spotting. For any doctor, those symptoms together are immediate flashing red lights.
So after a quick workup, the diagnosis is a suspected ectopic pregnancy. Now, if you don't know, that's when a fertilized egg implants somewhere outside the uterus. It is a genuine medical emergency. If that ruptures, it can cause catastrophic internal bleeding. It is absolutely life-threatening. So the resident does exactly what you'd expect. They get on the phone with their supervising consultants. But this is where the whole situation gets a major twist. The consultant says they can't make it in. But over the phone, they give a direct order. Get the patient into surgery right now. And that right there, that's the core of the whole problem. Let's just say for a moment that this senior resident is confident. I mean, they've assisted on this surgery dozens of times, they know the steps, they feel they can do it. But the real question is, in a situation this critical, is feeling confident enough? As you've probably guessed, the answer to that is a hard no. The decision to cut goes so far beyond just having the technical skill. There are a bunch of other massive factors that this resident has to weigh, and they have to do it in just a few minutes. So let's break down just how complicated this is. There are three big things to think about. First, the patient's condition is a ticking time bomb. Sure, her vitals might be stable for now, but that could change in an instant. Second, and this is huge, you've got the issue of consent. The patient agreed to be operated on by a fully qualified specialist, right? Not by a trainee. And third, the hospital itself has a responsibility to make sure its residents are properly supervised. That's fundamental to training. Going it alone completely undermines that. So what this really boils down to is a classic fundamental conflict you see in every single teaching hospital. It's this constant tension between the need to give the best possible care to the patient right in front of you versus the need to provide the best possible training for the doctors of the future. And this quote just nails it, doesn't it? The real challenge here isn't just about whether the resident should do the surgery or not. It's about figuring out how to do two things at once. Give amazing care to the person on the operating table and give amazing supervised training to the person holding the scalpel. Now, if the ethical tightrope wasn't tricky enough, let's talk about the legal dangers, because this isn't just an ethical problem. The resident is walking into a legal minefield, and they could be risking their entire career. The legal term you need to know here is something called ghost surgery. And yeah, it sounds a little creepy, because it is. It's what happens when the surgeon who actually performs the operation is not the surgeon the patient consented to have. It's a massive breach of trust. This chart here lays it out plain and simple. On the left, you have what the patient agreed to, an operation by an experienced senior specialist. On the right, you have what might actually happen, a resident still in training, performing that surgery without the patient having any idea. That gap between expectation and reality, that's the legal danger zone. And here's the part that is just absolutely shocking. Let's say the resident goes ahead, performs the surgery flawlessly, and the patient makes a full, perfect recovery. From a legal perspective, it doesn't matter. Without the patient's specific, informed consent for that doctor to do the surgery, the act itself can be considered assault and battery. A good outcome doesn't just erase the violation. Okay, so with all of these massive ethical and legal pressures, what was the right move? What should the resident have done? Well, thankfully, there is a much, much safer way forward that protects everybody involved. The correct protocol is actually pretty simple when you think about it. Step 1, the resident confirms that the main consultant really can't get there within a reasonable time, let's say 30 minutes. Step 2, and this is the most important part, don't just proceed alone. You go down the on-call list and you contact the next available consultant. Step 3, problem solved. The patient gets the expert specialist care they agreed to, and the resident gets the supervision they're required to have. And really, this brings us to the big picture.
Because the ultimate solution isn't about one single resident making one good call in a moment of crisis. It's about hospitals having crystal clear, ironclad policies in place for exactly this kind of situation. Policies that guide residents, that protect a patient's right to consent, and that protect everyone, the doctors and the hospital, from career-ending lawsuits.
So we end on this question, because it really is at the very core of all medical education. How do we train the incredible lifesavers of tomorrow without putting the patients of today at risk? It's an incredibly delicate balancing act. But as this whole case shows, the answer isn't about residents being lone heroes. It's about having clear systems, clear protocols, and an unshakable respect for the patient's consent. That's how we ensure we can train great surgeons for the future while always, always putting patient safety first.